Hi, and thank you for joining Aerogen's webinar titled Transforming Aerosol Delivery in Critical Care, the Role of Vibrating Mesh Nebulizers. With over 300 participants, this marks an occasional moment, being the first Aerogen webinar to be held for the APAC region. This is an Aerogen-sponsored presentation, and the views and opinions expressed are that of our guest speakers. Aerogen does not promote off-label use of its device or associated medications, and this presentation is for healthcare professionals only. On your screen, you will see an overview of the platform you're using today. Feel free to ask any questions using the box on the bottom left, and if you have any technical difficulties, please email aerogeneducation@aerogen.com. This is the agenda for today. There will be presentations from two esteemed speakers, Associate Professor Labassi and Assistant Professor Napalika, followed by a Q&A session. Displayed are the learning objectives. Both presenters will be presenting today, giving their views on aerosol delivery in critically ill patients. They will be sharing how they implement new technology like Aerogen VMN in their clinical practice. I would now like to introduce the featured speakers. On the left, we have Dr. Gianluigi Labassi, who is a senior intensive care specialist at the Prince Charles Hospital and the lead of Prime Lab within the Critical Care Research Group. He holds multiple academic appointments at the University of Queensland and Queensland University of Technology. His research and clinical focus center on advancing innovation in critical care and translational respiratory technologies. On the right, we have Assistant Professor Napalika Kongpo-Prom, who is the Assistant Director of Critical and Emergency Care at King Chulalongkorn Memorial Hospital in Bangkok, Thailand. With a strong background in emergency and critical care medicine, Dr. Napalika also serves as a faculty member and educator, contributing to the advancement of clinical practice and training in acute care settings. I will now pass over to Dr. Labassi, who will discuss his experience with VMN from an Australian and European perspective.
Thank you so much. Thank you so much, Natalie. And again, it's a privilege to be here to present during this webinar. And in the next few minutes, we're going to discuss nebulization, but I'm going to try to provide a little bit more international perspective. Now I'm at the Prince Charles Hospital here in Brisbane, beautiful Brisbane, Australia. We are in the middle of winter and the flu season over here. But before coming to Australia, I spent many years in Barcelona, where we work with many, particularly on nebulized antibiotics. And before Barcelona, I spent many years also at the National Institute of Health in the United States. And you can hear from my accent, originally from Italy. I trained in Italy originally, and then I moved for research in several places. Now, the group where I work is called the Critical Care Research Group. Is one of the largest critical care research group in Australasia, and he was funded and is led by Professor John Fraser, who is Louisian and Australian as well. And there are several opportunities, and this is also an opportunity for us to explain our research, but also promote the possibility for all of you to contact us for collaboration in research. Now, I want to start, and this is very important, about the history of nebulization. The Iberius papyrus was already discussing about nebulization in 1550 before Christ. And this is very interesting because we have been tried for many millennials now to try to deliver medication through nebulization. And I think this is very fascinating for the way in order to start this webinar. Now, the history of nebulization, the most important timeline is when the meter dose inhaler was started to be used in 1955, and then the ultrasonic nebulizer was developed in 1960. And what we will focus a little bit more today, vibrating mesh nebulizer was developed and introduced in medical practice in 2000. Now, the inhalation therapy in general is in terms of definition, is the use of an aerosol for respiratory care in the treatment of bronchopulmonary diseases in general. The inhaled aerosols allow selective treatment of the lungs, and particularly is very useful when you want to use drugs that they could be systemically with adverse event or potential complication. And always during aerosolization, you might have the chance to reach the lungs with a higher concentration. And this is very important for instance, for my area of expertise is, for instance, antibiotics. And many of these antibiotics, when they are delivered intravenous, they cause potential complication. The unit of measurement that is essential in this field is the mass media aerodynamic diameter. This is something very important because they give you an actual unit of length in order to reach the alveoli. And the optimal particle size to achieve deposition in the alveoli is between 1 and 5 microns. Now, why is so important this range of particle size? This is just because when you reach the alveolar, the 23rd generation of the respiratory tract, the size is between 0.5 and 3 microns, which means anything that is bigger than that will deposit in the earlier generation and not at the level alveoli. Sometimes you want something a little bit bigger if it's a problem with for instance, a bleeding in the proximal airways, but the vast majority of the medication they need to reach the alveoli. Now, the foundation of inspiratory airflow is another critical factor in nebulization of any medication, and in particular because you want to achieve laminar flow when you have you try to nebulize, because any turbulent flow, what it does is just increasing the deposition of medication in the larger airways. And this is could cause reduction in the deposition of the medication more distally. The unit of measure is the Reynolds number, and I'm not going to go for the sake of time in details, but there are specific factors that needs to be considered when you nebulize that are critical for distal deposition. Now, in terms of the devices, as I said before, there are several devices that can be used to aerosolize medication. Very likely, if you come like me from the intensive care ward, the one that we use most frequently are the pressure meter dose inhaler and the vibrating mesh nebulizer, but also many units use the jet nebulizer. The ultrasonic nebulizer is something that is more frequent outside the intensive care unit, so we're going to just touch on this briefly. Now, I would like to start with the vibrating mesh nebulizer. And this is because I strongly believe that has completely revolutionized the field of aerosolized medicine. So the way that vibrating mesh technology works, there is this plate that usually is completely disconnected from the circuit, and this plate is filtered from the liquid phase of the nebulization, which is the medication, and the airway, artificial airway side, where you want to deliver the nebulized medication. So there are these tiny holes in this plate that when the plate starts vibrating, create these small particles. It's very fascinating. These were two videos that they were at this stage they are not playing, but they give you an idea of how the nebulization is created. The underpinnings of vibrating mesh nebulizer is very important to understand how much of the drug that you are trying to deliver is actually delivered. And the best that you can deliver, the best dose that you can deliver with the vibrating mesh is just 30%. There is a very short, small residual drug volume, which is very important in order to avoid contamination or colonization. And there is also reduced risk of contamination because you are not actually in the circuit, but you are separated from the circuit. And very important, in order to not alter the medication, the drug temperature is not increased. We will touch base a little bit more later on where to place the vibrating mesh. In my unit, we use the vibrating mesh at the dry limb of the heated humidifier, but many other units, they use it in the respiratory limb. It needs to be most commonly in the respiratory limb, and they have also a spacer before reaching the Y-piece of the circuit. Now, in terms of comparison with other devices, this is a slide that I often present when I present about aerosolization. Look at, for instance, jet nebulizer. These are jet nebulizers. They have a drug delivery up to 10%. Ultrasonic nebulizer 17%, and MDI they reach up 20%. But this clearly tells you two things. First of all, that there's been a revolution with the vibrating mesh, but still the drug that you are trying to deliver, just a minimal part of this drug is actually delivered. These are PET studies. They usually nebulize radioactive solution, and then they measure the radioactivity into the lungs. And look at the jet nebulizer. This clearly demonstrated that just 3% was delivered into the lungs. And with the vibrating mesh, as I said before, you can reach up to 15%, but this is strongly affected by the ventilatory setting you're using. When you're using, for instance, pressure control ventilation, you're going to have a decrease of the delivery, and this is just because of the waveform of the inspiratory flow. Now, with the nebulized drugs, I do expect that the more we improve the technology, the longer is going to be the list of medication that we can actually nebulize. There's been, particularly here in Australia, in Brisbane, several attempts to nebulize even anesthetics or drugs like sedatives, but there are several medications that can be nebulized, and the vast majority of you, I'm sure, that have used bronchodilators, but that's just a small portion of the drugs that can be nebulized. So I'm an intensivist. I'm an intensive care physician, and most of my patients I manage are on invasive mechanical ventilation. And as I said before, is when you use these devices on invasive mechanical ventilation, there is a clear evidence that the farther away the nebulizer is positioned, the higher is the delivery of the drug. So for this specific reason, we use the vibrating mesh right at the inspiratory limb of the heated humidifier. Sometimes adding a spacer can improve the deposition, and the other things, try to be very careful when you use these devices on the geometric angulation. If you use, for instance, an elbow connection before the before the endotracheal tube, sometimes you have just the position when the angulation lies, because you need to have a straight circuit into the endotracheal tube to achieve the best deposit. This is a clear study from a very distinguished group led by Fink that clearly demonstrated in the blue bars you can see the use of vibrating mesh nebulizer, and it's clearly demonstrated that when you are a little bit closer to the endotracheal tube, like in this case, you are going to have a little bit less drug deposition because you need to be far away from the endotracheal tube. Now, in terms of ventilatory settings, Ruby and colleagues from France have investigated in vitro comprehensively this aspect. And as I said before, you need to aim for laminar flow. And in order to achieve the laminar flow, anything that create a lot of turbulence, like higher inspiratory flow or patient effort of coughing, all these things reduce the deposition of medication. Pressure control, we already discussed about pressure control. And what we do sometimes when we try to deliver aerosolized medicine, we change the ventilatory settings as well. We change to volume control, we reduce the respiratory rate, we reduce the minute ventilation, we add an inspiratory pause. These are just all critical factors that have been already investigated, and they are going to increase that 30%, that is the maximum amount of drug that you can deposit. In terms of other modalities, non-invasive ventilation and high flow, the non-invasive ventilation has been studied as well, but for many reasons, and again, for the sake of time, I do not have time to go in details on the reason, but you are reducing, even with the vibrating mesh nebulizer, your efficiency and deliver from 30% up to 5%. And most important, particularly if you're using these with patients with poor compliance or with the respiratory effort, you're going to decrease this even further. When they look specifically in patients with COPD, the actual improvement in spirometry with the use of bronchodilator with the nebulizer, and they compare with Gen nebulizer, there was always an improvement in clinical factors, improvement with the use of vibrating mesh. And this is just because whatever bronchodilation you're using is actually deposited at higher level using these devices. And The things are a little bit more complicated with the use of high flow, and this is because we are using flow that is not normally used in non-invasive ventilation. For instance, and particularly you have an open circuit because they breathe through your mouth when they inhale through their nose. What we know from PET studies, you need to reduce the flow in order to achieve a considerable increase in the deposition of the drug. If you have a 50 liters per minute, you should expect approximately 3-5% of deposition. Instead, when you reduce to 10, then you are in the normal level, like in invasive mechanical ventilation. This is a very nice review on the use of high flow and nebulization. Basically, the summary is that vibrating mesh nebulizer were always in comparison with other interfaces, and were always providing better resolution of the disease that they were trying to address with the nebulization, and also the deposition is higher with the use of vibrating mesh nebulizer. And I would like to conclude in the last few minutes just with a few slides on safety and AGP. Particularly AGP is something that, at least here in Australia, has been very a big concern in Australia for the use of nebulizer. AGP, for those of you that unfortunately have not encountered this word before, this is called aerosol generating procedure, and it's a major concern in every hospital because particularly when we admit a patient with COVID-19 or flu, you do not want to generate any aerosol because it's going to increase the risk for healthcare providers as well. Now, and I would like to emphasize this aspect. There is no international guidance, international recommendation that suggests that at this stage the use of nebulization, particularly vibrating mesh nebulizer or the MDI, increase the risk of aerosolization. And this is from both the research and clinical perspective is quite easy to understand, because unless you are breaking the circuit of invasively mechanical ventilating, or you are causing some coughing during the nebulization, just the nebulization itself, it doesn't increase the risk on top of the risk that normally all these patients they inherently have when they breathe and they cough. Irrespective of this, I'm an intensivist from Australia, and our governance is from NZICS, and NZICS unfortunately still list nebulized therapy as a potential procedure that could increase the aerosol, the risk of aerosolization. And even in my hospital, I'm in a major quaternary hospital in Brisbane. When in 2022 there was still nebulizer NAV for as listed as a risk factor for generation of aerosols, but then in 2025 finally this disappeared as was recommended by many of our specialty. And other hospitals in the region, I wanted to show this that these two hospitals, they are coming from the same group, but they provide completely different recommendation. And what all this is suggesting is that there is no clear evidence on the generation of aerosol with just the nebulization. And there are in vitro studies that have clearly demonstrated, in vivo as well, that clearly demonstrated that when even in patient with high flow or nasal cannula, the risk is not increased. And when you put a face mask, and this is very clearly demonstrated here, for instance, when you have a scavenger face tent or a face mask, every time you use a face mask, you drastically reduce the risk of generating aerosolization. But again, in comparison with the baseline, there is nothing significant that shows that you are increasing the production of aerosol. And I strongly suggest you to read this interesting paper that was they actually measure the concentration of aerosolization at 1 foot and 3 feet, and they always showed that when you put something so simple like a mask on top of the high flow, then your risk drastically decreases. So when I do aerosolization in invasive mechanical ventilation, I do not have any concern. On non-invasive ventilation, sometimes I tried to reduce the risk, but I know that non-invasive ventilation already reduced a little bit overall the efficiency of nebulization. And when I use high flow, I usually connect the vibrating mesh nebulizer already during a circuit setup, and this is very important in order to not disconnect anything afterward. I put the vibrating mesh nebulizer on the dry inspiratory lip, and the medication usually the nebulizer can remain in line for up to 28 days. So there are no problems at all in disconnecting the line. And again, I would like to conclude with a very interesting review from many of our collaborators in Europe and United States that clearly demonstrate and emphasize that vibrating mesh nebulizer is the first choice in nebulization, particularly mechanical ventilated patient, and in high flow patient using high flow as well. MDI is the other alternative, and particularly for the efficiency of MDI. But again, there are several advantages in using the vibrating mesh. In conclusion, I think, and many experts in this field think that vibrating mesh nebulizer have transformed completely the field of aerosol therapy. There are a wide range of medication, and we do expect that the list of medication will increase even further in the future, and this is because the device and research and development of medication will continuously increase and improve the field. And finally, I don't think, and many experts in this field think that there is no clear evidence that vibrating mesh nebulizer pose an aerosolization risk to healthcare workers at this stage. Thank you so much.
Thank you, Dr. Lavassi, for an insightful presentation. So next, I would like to pass it over to Dr. Napalika, who will give her perspective from Thailand, particularly around nebulization during and after the COVID-19 pandemic. Over to you, Dr. Napalika.
Thank you very much. My topic is the Thailand perspective, nebulizations during and after the COVID-19 outbreak. And I have nothing to disclose. And this is the outline of my talk. Let's start with the overview of the nebulizer used in Thailand. Generally, Thai physicians choose MDI over nebulizer as long as the patients can use them properly because they are more convenient and require less time to administer. And for nebulizations, traditionally, aerosolized medications have been delivered by jet nebulizers, and mesh nebulizer use is on the rise, but we face many challenges due to the cost, lack of awareness, and limited experience. In 2023, we conducted the aerosol therapy survey in Udon Thani Hospital, one of the hospital centers located in the northeast part of Thailand. The results showed the jet nebulizer is the most common aerosol device used during mechanical ventilations. PMDI is the second most common use. Mesh nebulizer is around 6% used during mechanical ventilations, and only 27% of the healthcare personnel had the experience in use mesh nebulizer. This year, we did the same survey in Rayong Hospital, which is one of the hospital centers in the eastern part of Thailand, and the results were similar to those in Udon Thani Hospital. And after the COVID-19 outbreak, there was increasing use of high flow nasal cannula in hypoxemic and hypercapnic patients. There is still limited evidence supporting the use of aerosol therapy during high flow nasal cannula. In 2024, we conducted the survey of the aerosol therapy practice during high flow nasal cannula use in our hospital. And we found that vibrating mesh nebulizer in line during high flow nasal cannula therapy is the most common practice. And the second common practice was stopping high flow use and applying jet nebulizer white face masks. And during the COVID-19 outbreak, nebulizers were a potential source of airborne virus. Nebulizer treatment is considered as a potential source of infection transmission by droplets, nuclear, and aerosols. And aerosol therapy generates fugitive emissions that are not inhaled by the patients and are released from the device during expirations. Fugitive aerosol remain airborne in the indoor environment for several hours. However, there is no data to support viable virus in the air outside of aerosol generating procedure from hospital studies. Jet nebulizers may expose healthcare workers to possible microorganism contaminations and or to the aerosolizations of the contaminations particle. Jet nebulizer opens and positions below the gas pathway. It can be contaminated by the patient's secretions or exhaled bioaerosols when they are directed connected to the patient's interface, and it may spill 2/3 of emitted aerosol into the environment. And that is the experimental study determining the extensions of the aerosol dispersions during jet nebulizer. They simulate the patients using jet nebulization and who exhales with the airflow rate 10 liters per minute and evaluate the viral load at head, abdomen, and feet, and average viral load at each of the sampling locations is at the head is far from the nose around 0.4, and they found that there are around 600 virus per liter, and at feet is far from the nose around 1.7 meters. They found virus around 120 per liter. And this experiment was conducted within a chamber with 12 air change per hour, which is typical in the single isolate room. And if the patients use the jet nebulizer in the less well ventilated room, the airborne virus concentrations may gradually increase over time. Moreover, aerosol dispersions depends on the severity of the lung disease. Severe lung injuries disperse the particle beyond 0.8 meters. Mesh nebulizers generate aerosols via mesh plates that separate the sealed medications reservoir from the patient's interface. And during nebulizations, the aerosol device from the fluid in the nebulizer chamber and does not carry the viral particle. Mesh nebulizer has more advantages over jet nebulizer, such as the low residual volumes, high dose reproducibility, and less drug loss during exhalations. Moreover, mesh nebulizer has low risk of particle contaminations and airborne transmissions. The medication's reservoir is isolated from the breathing circuit that eliminates the nebulizations of contamination fluid. In the early COVID-19 pandemics, the guidelines and expert committees recommended using mesh nebulizer during mechanical ventilations because there was no need to disconnect the ventilator circuit. The protocol of aerosol therapy in our hospital during the COVID-19 outbreak. At the beginnings of the COVID-19 outbreak in Thailand, we conducted simulations to prepare our staff to respond to the crisis, and we simulate the patients to develop impending acute respiratory failures, and our team had to go to do resuscitations, and the patients was intubated and ventilated manually, and we determined the extensions of the particle exposures. All of our team were contaminated with the aerosol particles as shown. And this helped optimize our protocol and convince our team to comply the hospital protocol. And this is the protocol in our hospital during the COVID-19 outbreak. Use of the PDI with or without spacer as an alternative to nebulizers. And nebulizers should be only used in the isolated room or negative pressure rooms, and prefer use the mesh nebulizers over jet nebulizer, and ensure to use the proper protective equipment. For the nebulizer, mouthpiece is preferred patient's interface over the face mask, and place a filters on the exhalation port to lower the viral concentrations of the fugitive aerosols and decrease the secondhand exposures to aerosol medications. However, during the outbreak, there were a shortage of the filters, so we allowed to use the nebulizations without a filter in the isolated room. And there is increasing use of the high-flow nasal cannula during the outbreak, and nebulizations with the high-flow use decreased lung deposit. And these are the study that compare. This study is compared the aerosol depositions with nebulizations with mouthpiece and mask alone or with the high-flow nasal cannula. And you can see that when nebulizer used with the high flow, the aerosol deposit decreased. And to compare with the nebulizer used alone on the left side, mesh nebulizer with mask with the high flow decreased the lung deposit from 36% to 4%. And if compared with mesh nebulizer with the mouthpiece and with the high flow, it decreased the lung deposit from 28% to 3%. From the jet nebulizers by mask with the high flow, it decreased the lung deposit from 9% to 5%. And for the jet neb via the mouthpiece with high flow, the lung deposit is only 0.557%. And however, when we use the mesh nebulizers placed in line, the aerosol deposit was 7%. And to maximize the lung deposit, mesh nebulizers should be placed before or after heat humidifier, and use the larger cannula is preferred. And jet nebulizer by mask with the high flow nasal cannula is not recommended. and jet nebulizers can place in the inline before and heat humidifiers. However, inhaler dose delivered via mesh nebulizer is 2 to 3 folds greater than that via a jet nebulizer. And there is the studies comparing the effect of salbutamol administered with high flow with mesh nebulizers versus jet nebulizer alone on the lung function in the patients with stable CO. And the bronchodilator therapy via the mesh nebulizer in line with the high flow was not inferior to jet nebulizers. And mesh nebulizer in line with the high flow improved the airway oscillatory mechanics indicated by the lower respiratory resistance area of the reactants and resonance frequency and reactants compared to jet nebulizer. And while using high flow, that at 2.2 meters from the patients, the caregivers were exposed around 3% of the nebulized loading dose. So the surgical mask should cover the nose and the mouth of the patients during the treatment. And to reduce the risk of airborne transmissions, the use of the mesh nebulizer during mechanical ventilations for the certain ducts is mandatory. MDI use during mechanical ventilations is allowed, and we did not use the heat moisture exchanges to avoid the circuit disconnect during the treatment, and we use the filter attached to the exhale port of the mechanical ventilators instead, and we train the personnel to administer it properly. And we did not allow to use jet nebulizer during mechanical ventilations because it's required to disconnect the ventilator circuit. Although jet nebulizer can be placed prior to the humidifiers, drug delivered with the mesh nebulizer was 2 to 4 fold greater than with the jet nebulizer at our position. Overall, the mesh nebulizers demonstrated a 25-fold higher depositions of aerosol in the lungs compared to standard nebulizations with a lower residual volume. I will show you some cases. There were several cases. COVID-19 cases that needed bronchoscope to remove the secretions due to the obstructive atelectasis. In this case, the patients had right modular atelectasis and recurrent left lung atelectasis despite treatment with the mucolytics and hydrations. And in the other case, the patients had a recurrent right lower lobe atelectasis. So we developed the protocol to using hypertonic saline 2 to 3 milliliters via the mesh nebulizers every 2 to 6 hours, depends on the severity and frequency of the secretions obstructions. And after we provide this protocol, the numbers of the patients who need bronchoscopy to remove the secretions is lower, and the number to use the not only the numbers of the bronchoscopy, the number of the patients that need to use it is lower as well. And this is a protocol after the COVID-19 outbreak. We still prefer to use mesh nebulizer instead of jet nebulizers when high flow or mechanical ventilation is being used, and prefer using mesh nebulizer in case of airborne precautions and using mesh nebulizer with a certain medications. To conclude, in Thailand, aerosolized medications have been traditionally delivered by used jet nebulizers, and mesh nebulizers are now preferred devices for the treatment of the high-value drugs, and vibrating mesh nebulizers are increasing in use after the COVID-19 outbreak. And thank you very much for your attention.
Thank you, Dr. Napalika. It's really great to understand the current nebulization situation in Thailand. It was a wonderful presentation. So now with the time that we have left, we will now head over for a Q&A session. So this one is a question that has come through, and I will direct it to Dr. Labassi. So Dr. Labassi, from the presentations, we could see that the bench and imaging data that was presented shows that lung deposition or lung drug deposition is significantly higher with a vibrating mesh nebulizer compared to conventional devices. Can we get your thoughts on this? Like, do you see more adverse events in practice, and are there any concerns with safety using the vibrating mesh nebulizer compared to a conventional device?
Thank you, Natalie. Can you hear me?
Yes, we can.
Oh, perfect. It's an excellent question. And it's an excellent question because, again, we are talking here about 30% of the drug that is supposed to be delivered. But most of the investigation about safety has been done particularly on use of antibiotics because, yes, when they look specifically at epithelial lining fluid, in that context, they found a concentration of antibiotics that was up to 4-6-fold higher than the normal concentration that are needed for bacterial killing. Having said that, the use of antibiotics, nebulized antibiotics, has been also the part that has been mostly investigated in terms of adverse event. Herman study, the beautiful study in New England, Niederman study, Kolev study, they all investigated the potential adverse event. And when you look collectively at all the data from this safety profile, the data unequivocally confirm that safety, that vibrating mesh nebulizers are safe. Indeed, for instance, for the most concern that clinicians have when they use nebulization, specifically with antibiotics, when you look at endotracheal tube complication, when you look at bronchospasm, none of these studies has ever demonstrated a higher risk of this complication. And this gives us a lot of room for the use of these drugs. This cannot be extended with all the drugs, and particularly with the drugs that will be introduced in the world of nebulization later on in future years. But for what we know now, the drugs that have been delivered, the safety profile was absolutely unequivocally with a very good profile.
Thanks, Dr. Labassi, for providing your opinion on this question that has come through. I'm actually going to just switch it over to Dr. Napalika. There is a question that has come through for you. So, Dr. Napalika, the data presented today shows that when administering nebulization with vibrating mesh in line with high flow, as you increase the gas flow rates, the drug deposition is reduced. So could you please share with us some strategies you do to potentially overcome this?
Okay. When I use the vibrating mesh nebulizers in line with the high flow nasal therapy, I will observe the patients. If they can tolerate with the low flow rate, I lower the flow rate. Such as if they use the flow rate around 30 or 50 liters per minute. I try to reduce to 10 liters per minute if they can tolerate. It will help to improve the lung deposit. And sometimes we need to titrate the FiO2 to maintain the oxygenation. However, if they cannot tolerate with the lower flow rate, sometimes we have to increase the drug dose to increase the lung deposit. And from the recent study, some studies show that if we adapt the high flow and connect the cannula and replace the cannula with the mouthpiece, it can improve the lung deposit. But in that study, the patients cannot tolerate the mouthpiece during the high flow nasal cannula. The key is the lower rate of the high flow rate is the better lung deposit. If you can the lower rate, I think it's improve the lung deposit and the patient's outcome.
Wonderful. Thank you. Thank you for answering that question, Dr. Napalika, that came through. Now, so just switching it back to Dr. Labasi. So really depending on the region, when we're talking about device cost basis, vibrating mesh cost is slightly higher than the conventional devices. However, when we are considering the patient journey, Dr. Labasi, what are your thoughts on this?
Yeah. Thank you. It's a little bit a challenging question, this one, but again, my recommendations regarding the selection of a slightly more expensive device over absolutely cheaper alternative, I think need to be guided on the specific goals you're trying to achieve with your patient. We are in the era of personalized medicine. And as a clinician, as an intensivist, absolutely I do not advocate for changing the aerosolization interface across an entire unit, an entire hospital. This is not what I think a wise clinician should do. Vibrating mesh nebulizer have demonstrated superior performance compared particularly to MDI in multiple in vitro and vivo studies, but and this is something that needs to be considered because efficiency is paramount for cost reduction. When you look, there is a very interesting study from the emergency department in Detroit from Robert Dunn and Sandra Short, that they clearly demonstrated that when they were nebulizing with the vibrating mesh instead of jet nebulizer, bronchodilators in patients with COPD, they demonstrated fewer hospital admission, shorter emergency department stay, and also a good outcome for this patient. And this is what you need to try to achieve with nebulization. But it's essential to consider the individual patient. Herman study on antibiotics, they didn't show length of stay differences or other outcome, but they did demonstrate prevention of ventilator-associated pneumonia, which I don't know in the entire EPIC region, but in Australia is considered iatrogenesis for patient is considered an expensive iatrogenic event. So regarding the associated cost, I think our primary responsibility is to minimize cost for the patient. And Natalie, can you hear us?
Natalie, we can't hear you.
Oh, that's why. So sorry. I was on, yeah. So this next question is for Dr. Labasi. Where do you see the research for inhaled therapies heading? And what inhalation devices would you consider for your research?
Oh, thank you so much. Again, I'm 60% researcher, 40% clinician. So this is a very interesting question. So this is a nebulization, as I said before. It comes from Egyptian times. So but despite a significant advancement, particularly with this new nebulizer, we are still achieving 30% of the intended delivery dose. So we need to work on the optimization of the interface, specifically vibrating mesh nebulizer, in order to optimize the drug delivery. We are in the era also of artificial intelligence, so it's very easy to gather data from the ventilatory setting, from the medication, in order to understand what are the best profile in order to improve delivery of these drugs. Medication. As I said many times during these webinars, we are going to expand on the use of medication that can be delivered through aerosolization. And we are just at the very beginning of pharmacokinetics, pharmacodynamics, in understanding the use of this nebulized drug, and particularly modification of these drugs in order to create a stable, non-irritating, and drugs that can be safely delivered in order to achieve curative roles. And then, and this is very important for me to conclude, monitoring. In 2025, currently, there is still no reliable method to deliver, to monitor the delivery of nebulized medication. We assume that this medication will reach the alveoli, but we do not have visualization of that reach to the alveoli unless we go to the PET scan, and many times it's almost impossible. So monitoring will change the field if we can pursue and achieve a monitoring interface that can actually image the delivery of this device. Thank you so much for the question.
Thank you. And thank you both, Dr. Napalica as well as Dr. Labasi, for joining us today. It's been a wonderful presentation, and on behalf of Aerogen, I would like to say a big thank you to our esteemed speakers. And now to close off, for those who will be joining APICS this year in Singapore, please join us at the Meet the Expert session with Professor Stefan Ehrman on August 15. You did hear Dr. Labasi mention him a few times, and the details have been flashed on your screen for the past few minutes. And then lastly, Aerogen want to thank you for your participation with this remarkable